Hello, my name is Marie Gascoigne and I lead Better Communication KIC, which is a not-for-profit organisation supporting change in the children's workforce. And I'm also a speech and language therapist by background and the developer of the Balance System framework. Today, I'm going to give you the briefest overview of the framework itself with signposts to lots of more detailed information for those that might be interested in that. But really then move on to focus in this very short video on the challenge of workforce and the opportunities for workforce in thinking around this particular way of organising our services. So why the balance system? Let's start with that, shall we? So this conundrum has in fact been one that has been vexing me for 20 years now. In 2006, I was pleased to author the position paper for the Royal College of Speech and Language Therapists, which includes some of the initial principles that were emerging around being integrated in our workforce. At the time that that was written, children's trusts were very much on the agenda. And so the beginnings of the ideas that sit underneath this core way of working started in that document. In 2008, that crystallised into what is now the core graphic that tries to capture the whole system approach, which I'll come back to later on. And then I'm not going to go through these, but threaded through the Burko review, the subsequent commissioning guidance, various publications across the years, the model has been constantly referenced and developed. And the very latest publication, should you be interested, literally it's hot off the press. And if you scan the QR code, you'll be able to access it. Okay, so what is the balance system then? Well, it's a strategic framework for understanding need in a particular population, at any specific population that you identify, and then developing the services to meet that need. So being population-based and taking that very social, ecological, public health type approach to understanding that need, it isn't led by diagnostic categories, although obviously data that's known around specific groups of individual children and young people is taken into account. It focuses on measuring impact over input and not being over-dominated by measures of input, as sadly some of our systems often are, because counting things is, let's face it, easier than trying to measure whether we actually made a difference. It's a high-level systems outcomes framework, so it's all about outcomes. Outcomes come first and at the centre, and those outcomes are around what children, young people and their families want to achieve, in this instance through the frame of their speech, language and communication skills and challenges. And so to organise those outcomes, we have 5 strands and 3 levels, which I will go into a little bit more detail in the next couple of slides. And in order to deliver that framework, those high-level outcomes across a system, we've identified over the years of working with a number of lots of different areas, in fact, across the UK and in fact even beyond, that these 5 delivery principles are really core to making it happen. And I shall go into those in a moment. So, let me just bring up all these graphics at once. There we go. So on the left there, you have that graphic, which I referenced back to 2008, which encompasses what it's all about as best I can. So starting at the very bottom, there are 3 building blocks in grey, sort of granite foundations, if you like. And they are about having jointly commissioned or at least jointly aligned and owned outcomes across the system area for children, young people and their families who are experiencing any challenge at all, in fact, in terms of their speech, language, communication, as we're looking at it today. But this can be and is being applied across a range of other particular areas of need. But having that shared ambition across agencies and across funding streams is really, really key. This all started back in 2003 by the fact that for the Department of Education, speech, language and communication needs challenges were their biggest postbag of complaints. But for the Department of Health, it wasn't rearing its head above other priorities such as the big hitters, the cancer, etc. And children's services within that have an even lower profile, or have had an even lower profile. So this was really the challenge that was before us, and the solution that's proposed through this philosophy behind this framework is that actually we need to get it right just at those basic levels, and here we all still are. So I'm ever hopeful, but the reality is it's clearly a hard ask. But we want to have that shared conversation, and that's something that is possible when we bring services and systems together. The second building block is around an assumption and a really core philosophical decision that an integrated workforce is the way to do that. Having people in silos based on their employment status or who's funding them or who's funding this element of their work on this day of the week is really unhelpful. We're dealing with populations of children and young people in geographies, and wherever we're coming at it, whichever angle we come at it from, whether we're an educator, a social care worker or a health worker of various persuasions, we are dealing with the same children and young people, and therefore it's crazy that we do so separately. We have to work in an integrated workforce. And the third foundation is that we engage and genuinely collaborate and co-produce with our families and our young people what that looks like in a given area where the nuances will be different. They're the building blocks, and then on top of that we have the delivery model, which involves an emphasis on strong leadership, which is absolutely crucial to make anything happen, because this is counterintuitive to how some of the systems are set up around us. And then we have a plank of training and development that is basically underpinning everybody's practice for whichever particular perspective you are coming. And then on top of that, we have the idea that whatever we do has to have that graduated offer across universal targeted and specialist levels of support. And that language is commonplace sitting here in 2024 as we are. But believe it or not, when that was introduced in the 2006 position paper, that was new news. So we've come a very long way, and we can see how that language has spread across our children's workforce. And alongside that, we're trying to capture the idea that the wider workforce, that's everybody, and the specialist workforce that might have particular skills around a particular area, in this case speech language communication, have an equal role to play across all of that continuum of offer, and more of that shortly. And then on top of that, we have the outcomes framework itself. And on the right-hand side, that's pulled out a little bit to talk about 5 areas of outcomes to do with family and young person support, outcomes to do with environments, enhancing, adapting environments to be more accessible and supportive, outcomes to do with our workforce competence and confidence and quantity, which we'll be coming on to specifically in this video, outcomes to do with identification of need, and outcomes to do with intervention. And all of those have a descriptor, if you like, at a universal level, at a targeted level, and at a specialist level. And that brings us then to this grid, which is very dense and is just for illustration for the sort of scaffold of the framework itself. But the high-level outcomes then cover these 15 areas. So for each of those 5 strands, there are 3 different levels of outcome area that we might want to be meeting. And the proposal, if an area wishes to go down the route of trying to implement this particular way of working, is that when we get to wherever we decide our milestone marks are, we're going to be measuring ourselves against, are we able to evidence that we are actually delivering to these outcomes in all of these boxes? That's not to say that any one agency or any one professional area or group is responsible for all of them. It's absolutely saying the opposite. It's saying, as a system, can we evidence this? And in fact, it's going further than that. In a different context, we'd have more time to delve into this aspect. But actually, what is the unique contribution that each element of the system and each element of the workforce makes to each of those outcomes? Because there's a really strong message in here that nobody has the gift on their own to deliver any of these unilaterally. And that's really, really important. So in terms of those core delivery principles, we've identified a number of key activities that are essential in a system that's transforming towards being able to say that those outcomes are indeed true. So at the very base, driving the whole system is that reference to measuring impact and shifting away from just measuring inputs. And again, there's another whole set of materials that we can share around that in more detail, but let's leave that for today. There's three key elements that sit in the middle of the engine, if you like, and they are being accessible, so challenging traditional linear processes which require only one way of getting from A to B, where you have to have a referral, you have to then wait, typically, you're then assessed, go through an assessment process, and then, if you're lucky, there's a package of intervention at the end. It's saying, let's turn it on its head, and actually let's take our experts out into the field and try and be as accessible as possible to give people advice, information, signpost, and identify those that need to have an accelerated journey through to that more in-depth assessment and processes. That's the access part of the delivery, that's the access delivery principle, if you like. And then the second part of this trio is being place-based. So children and young people are where they are. They need to be using their language and communication skills in a functional way. We need to go to where they are doing that. And that is seldom going to be in a clinic setting. It might be for good reasons, or with the exception rather than the rule, but in terms of our planning and delivery of services, it's challenging ourselves to think about where's actually the best place. Another really important element to this, which is absolutely crucial, is thinking about how we are therefore more accessible to families. And we know from years and years and years of various different initiatives across the public sector that for some families accessing services is difficult. And so how do we make that as easy as possible? And part of the solution to that is going to where people already go and being there. So that's about being at a place, whether it be visiting homes, if we're talking about a young child, or a situation where that's appropriate because the young person is spending most of their time at home, but thinking about how we can organise ourselves to be accessible to early years settings, family hubs, and schools, and obviously beyond that into FE and so forth. And the third part of the engine is ensuring that in that offer that we have, of course, that universal targeted and specialist layers of interventions and provisions and strategies that we might have in the system, that we really do have the targeted layer. Because if we don't, there's another graphic that we use sometimes, what we create then is a vortex where there is no option to be sucked up into the specialist layer from the universal without any opportunity to have need met in that middle portion. And that's really, really important. And then finally, last but by no means least, is about information and how we actually ensure that everybody in our local system understands where they can get the right information, where they can signpost people to, whether it be a family accessing information for themselves or a young person, or indeed any of our practitioners sharing information around what colleagues have to offer. Okay, so just a couple more slides, and then we'll just think a little bit more about the conundrum of workforce. So this is leading us into that direction. So on the left-hand side there, you have a pyramid which could represent a population analysis. And we frequently start there. We start with who have we got in the population. And if we're thinking about our population in a given area, we think about all the children and young people. So we literally look at the population data. We think about then of those, the sum, the middle group, and these are deliberately not defined into any numerical terms, that the large group of high frequency needs that will exist in any population, but will perhaps have some nuances around risk factors, which we'll come on to in a second, but a significant number. And then the relatively few who have the more complex profiles and perhaps low incidence types of need relative to the whole population. And then in the middle, we have that universal targeted and specialist offer represented there. And on the right-hand side, we have our workforce pyramid. And here, what we're doing is saying, okay, we've got everybody that works with children and young people in terms of that big, wider workforce in our integrated system. We have some that will have some enhancement in their skills and confidence and competence around a particular area. So, for instance, a teaching assistant that's had additional training and has a higher level practitioner now may have a formally recognised level 3 qualification around speech, language and communication in this instance, for instance. So that wider group in the population and of our workforce. And then we have our specialists in the workforce, which clearly in this this instance comprise our speech and language therapy workforce, but also other specialists in the system that have enhanced knowledge and skills around child development and speech, language and communication as part of that. And what I want to do is just quickly introduce the notion that, again, there is no predetermined possibility of saying for any individual child or young person what the right route for them will be across these three pyramids. So it may well be that last horizontal line that's come in that said, I'm a complex child, I have specialist needs and they need to be met with by a specialist workforce. But equally, we have all those other options which show us that we could have a complex child who, if we're looking at impact, may have their needs actually more impactfully met by having targeted interventions in the places that they are every day with the people that work with them all of the time. And it's not an either or, and that's the other key part of this whole philosophy, is what should be possible is for all of this to happen simultaneously if we get our system building right, where it's necessary. And by doing so, we unblock some blocks that are built into the system by rigid pathways, which again is another whole conversation, not for today. Okay, so the workforce conundrum, which is what we're particularly focusing on in this presentation. So I'm going to go right back to a piece of smart art that was actually the very first version of the balanced system when I first presented it in 2008 to a conference to persuade John Bercow that he should listen to some of these challenges that we were facing. So if we take this piece of word smart art that's a familiar scales, I'm sure you've used it yourselves in various contexts, but today I'm going to just focus it on our population need and what we mean by that and how we might think about that, and then our workforce to meet that need. So if we think about the population need, we have the size of the population, as I said at the beginning. That's clearly a factor. We have risk factors in the population, and what we're very fortunate about in the field, in the sector of speech, language and communication, is there has been significant research looking at risk factors in early identification, looking at natural histories of speech, language and communication need, and identifying what some of those factors are. And so that if we know what those factors are, we can measure some of the indicators in a given population that help us understand those, we can layer that on top of the population to hone in what that population need might look like. So it's not just a number. I seem to have lost my risk factors there. There we go. And then we have our evidence base around what we might expect in terms of prevalence of different types of need in a given population. And I said at the beginning, it wasn't diagnostic category led, it's not. However, that's clearly part of it. So, for instance, where we have evidence that we can expect to find a percentage of children and young people presenting with a particular kind of speech and language communication need, regardless of some of those other factors, clearly that has to go into the mix. But then we can also nuance, based on those other risk factors, how much more we think there might be in terms of need in that given population. And that allows us, for instance, to think about the challenge that a speech and language therapist serving a population in somewhere like the centre of Manchester or Birmingham might face versus a whole-time equivalent speech and language therapist facing the needs of a population in somewhere like Hampshire, where we would have an expectation that the situation there would generate a somewhat different profile of need in the population. Some of those needs would be constant because they're not impacted by those risk factors, but others would be variable depending on those risk factors. And that's the really key important prediction of need calculation that we're able to use by taking this particular approach. However, what's the workforce to meet that need? That's the $6 million question. Well, we need to know about the skills and number of wider workforce. So we need to know who's in that middle bit of that population pyramid that I referred to, who has had some enhanced development training, and are they using it? That's the really key thing, because we also know that delivering training programs without any relationship building and coaching and follow-up from those with more expert knowledge to share is actually really not that valuable. There are, again, not for today, but I could go into some examples where that's actually been shown through differentiated randomized controlled trials. So we know that it's the support and confidence maintenance in terms of implementation that's really key, but it's irrelevant if we don't have the people there in the first instance and they're not provided with that opportunity to develop those skills and competencies. So who's out there in our wider workforce? What do they know and how are they using it? And is it being impactful? That's really, really key. And then on top of that, we clearly need to know the skills and number of our specialist workforce. And we know that we have got some challenges around recruitment and retention of our experts in the field, and lots of issues which you're going to talk about potentially amongst yourselves in terms of what that might look like. But actually, we still need to count those individuals, and that provider picture is variable. Some of it, the majority of it, will probably be identified through NHS services, but there are also increasing amounts of core provision that are being provided by colleagues that are working independently or in the third sector alongside. And all of that needs to be captured in a given area to really understand the workforce to meet the needs of the population. But as you can see, this is not a balanced system at the moment. We have a challenge here, we have a question mark. And so in my attempt to be a bit wizzy, you can see I've now suggested that we can balance the scales. And the bit that's missing is understanding whether or not we have that whole system service delivery model into which to feed all of this information and through which the workforce can work together. It doesn't have to be that. The proposition of this particular approach is saying that if we get that right and we then understand our population need and understand our workforce, that we can actually come to a point where the system can be balanced. Okay, so key factors to consider in terms of this conundrum. Is the current model of service delivery truly whole system in the area that you're working in? If not, it's likely that the impact of direct interventions, when they happen, will not be maximised. They'll be going into a black hole and not necessarily being the most benefit being gained from those interventions. And I should just say, by direct intervention, I mean anything that involves a speech and language therapy colleague actually working with an individual or group of children, or indeed a class of children, but they're all direct interventions of one sort or another. So we do not mean only one-to-one intervention. How integrated is the specialist workforce with the wider workforce across your local area? And do you know that? And how do you know that? Again, if the two are just talking to each other and going right back to that 2006 position paper, there's a diagram there drawn from other colleagues around the difference between multidisciplinary, interdisciplinary and transdisciplinary working. And if we're talking about a really integrated workforce, we're talking about one that comes together before any individual child or young person is considered and thinks, how do we organise ourselves so that we present as one to our community that we're here to serve? Interdisciplinary, we have decent conversations about it and we liaise, and multidisciplinary is actually the least integrated, and that's literally we all do our own thing and we come together and say what we've done. So how integrated is the specialist workforce in your area? And there are some self-evaluation tools that I can signpost you to another time on our website link at the bottom there that you can download and have a play with. If it isn't, then it's likely that the impact of any direct interventions will not be maximised, and that is a sad truth. Last one actually focuses on impact. Is impact the primary focus of your outcome measurement? Because if you're only counting inputs and counting beans and minutes spent, you won't actually know if you've made any difference at all. So if it isn't being the primary focus, if not, it's likely that the impact of direct interventions will not be maximised, but worse than that the impact of the whole system will not be evidenced at all. And that's the challenge that I would like to conclude this short video with. For you to think about. And there's just some